Good afternoon, everyone. I've got 2 o'clock on the dot, so we'll go ahead and get started. My name is Amy Mock. I am the Perinatal Quality Coordinator for the Georgia Perinatal Quality Collaborative and wanted to welcome you today with our afternoon session of laying the groundwork for a maternal cardiac program and an overview of the Georgia PQC cardiac education resources. So thank you for being here. This is recorded. We will place it on our website after the session today. So please feel free to share with colleagues or partners. Lisa, if you could advance the slide. So just some of our updates today. Our next maternal webinar is scheduled for September the 5th. The topic is Georgia PQC Maternal Data Quality Improvement Review, Hypertension Program Updates. Hypertension and cardiac Q2 for 2023 data submission was due yesterday. So if you have not gotten that in, please submit that as soon as possible. Also, just a reminder that we do always take back data. If you have not submitted some of that, please feel free to send that in to us. And then we wanted to provide you with information. The AIM will be updating their cardiac data collection plan in the very near future. There were some changes with their ICD codes. So once that's released, we will send that out to everyone. Next slide, please. As always, we like to share our key driver diagram with you. Talks about our goals, our SMART aim, and the key drivers for our cardiac initiative. So please feel free at any time if you have any questions, reach out to myself or Lisa regarding the maternal cardiac conditions. And so on with the show, so to speak. I wanted to introduce Heidi Enrique. Heidi comes to us where she has worked in health research for the past 15 years with a focus on health literacy and shared decision making. Heidi has received her graduate degrees at the University of Georgia School of Public Health and Health Promotion and Behavior. She worked at the CDC as a fellow in injury prevention and subsequently worked in health prevention programming in Germany for 3 years. Since joining Northeast Georgia Medical Center in 2020, Heidi has supported investigator-initiated research and is currently the director of the HOPE program for Georgia moms. She is a Master Certified Health Education Specialist and a Certified Professional for Clinical Research. And then also Bridget Schulman. Bridget has over 20 years of experience in women and children's services. Bridget has a master's in nursing education and also completed her PhD in nursing. She's certified in inpatient obstetrics, external fetal monitoring, and is an A1 fetal monitoring instructor and obstetric patient safety instructor trainer. Bridget served as a bedside nurse in labor and delivery for 10 years, the nurse educator for labor and delivery, the clinical practice specialist of the Women and Children's Services, and currently serves as the clinical outreach specialist for the grant Hope for Georgia Moms. Bridget is passionate about patient safety, which led her to also obtain the Certified Professional in Patient Safety credential from IHI. She uses her knowledge and experience to continue to improve equity, quality, and safety of maternal and perinatal care for all birthing people across Georgia. So please help us welcome Heidi and Bridget as they go over the grant Hope for Georgia Moms, as well as discuss their maternal cardiac program at Northeast Georgia Health System.
Thanks, Amy, and good afternoon, everybody. Today, I'd like to talk a little bit about our grant, the Hope for Georgia Moms, about what we're doing, and also ways that we hope that we can support what you're doing and to improve maternal health within your health systems and organizations. So the grant is officially called the State Maternal Health Innovation and Data Capacity Program. And we call this HOPE, which stands for Healthy Outcomes and Positive Equitable Experiences for Georgia Moms. And these are the project staff. So I'm Heidi Ehrenreich, the project director, and Bridget, who was just introduced, is our clinical outreach specialist and will be talking right after me about the implementation of maternal cardiac program. Maribel Luviano, our program coordinator, and Mary Lou Wilson, who's our executive sponsor of the grant from Women's Service Line Administrator at NGHS, sorry. Next slide, please. This grant, Healthy Outcomes and Positive Equitable Experiences, or HOPE for Georgia Moms, is a grant from HRSA, which is the Health Resources and Services Administration. And they awarded 9 grants in the US, and we were one state to receive that. And it was awarded to NGHS, so we're administrating it from NGHS, Northeast Georgia Health System. And from our cohort, we're the only health system to have received this grant. There are others from academia or from state health departments. So we think we're uniquely positioned to work from within the clinical setting and understand what the constraints, but also the opportunities are to work and help improve maternal health programming and outcomes in the state. This is an award that runs for 5 years. It started in 2022, so runs until 2027 and is for $5 million. And the purpose of the grant is to reduce maternal mortality and improve maternal morbidity and outcomes, and especially to reduce the health disparities that we know exist in terms of outcomes. And there are sort of 4 areas where we are working on strategies, and we're trying to address the through direct clinical care, trying to improve the workforce training, improve also maternal health data capacity, which is in particular the AIM data that are being reported by health systems, and improve community engagement. And there we're looking to include persons with lived experience and engaging them. And when we're doing the strategic planning, we really want to focus on innovative maternal care delivery services and equity, and to improve that. Next slide, please. So these are the 3 focus areas that we're currently working on at Hope for Georgia Moms. We are building a Georgia Maternal Health Task Force. We're trying to improve, again, the capacity for maternal health data in Georgia. And third, we're looking at maternal cardiac program. So with the Maternal Health Task Force, we are building a group of key stakeholders in Georgia who are working towards improving maternal health. We see this as an advisory council that will give this strategic direction and the programming needs that would be actionable steps in line with those strategies over the 5-year period. And we've invited persons from, again, academia and research centers in Georgia, from state health departments that are working in maternal and child health, from health systems, from community organizations and payers. And we're trying to leverage the knowledge, the experience, the existing programming out there, that we work together to not duplicate, but we can create sort of new strategies, sort of with this new constellation, but build on what's existing. And what we're doing now, by the end of fiscal year 1, we want to, or we have to actually, for the HRSA grant, we have to deliver a draft strategic plan. And then we have a retreat that we're working on with our maternal health task force members and others that are invited. And I'd like to tell you a little bit more about that so that you would consider also these opportunities. Next, maternal health data in Georgia. That's important for us because we are collaborating with GaPQC and the AIM bundles that are being implemented with the Maternal Mortality Review Committee, or MMRC, Title V programming, which is support that's given, federal support that's given to the state for implementing maternal and child health programming, and the regional perinatal centers. And we're trying to improve and make it easier for the health systems to contribute the AIM data collection across the health systems. And one way we are doing that, we hope, is by piloting a maternal health registry, which we've created in Epic, and creating data dashboards. And we're hoping that that can be a way for other health systems to more easily report the AIM data that they need to report. And another large part of the data reporting is that we need to report to HRSA so that they have an understanding in terms of surveillance across the US and what's happening, what's contributing to maternal mortality and morbidity. And we'll help support that by delivering a report called the Maternal Health Annual Report, also due at the end of this fiscal year. And then finally, the big piece of what we're doing right now is the maternal cardiac program, and we're piloting this at NGHS. We're conducting a rigorous evaluation and a cost analysis of this process. And we're also looking to add components of remote patient monitoring and telehealth so that we can reach more distant patients that are not coming to our systems, and also in rural areas. And the idea is that we want to disseminate these pilot results to other health systems across Georgia. And this is what Bridget will be talking more about, so that we can reach this population of pregnant and 1 year postpartum women, which is the focus of the maternal cardiac program. Next slide, please. I wanted just to give you a little bit a better idea about the Georgia Maternal Health Task Force, with the idea that maybe you have ideas of how you can contribute. This is a growing and dynamic sort of process in identifying the key stakeholders for the Maternal Health Task Force. This is a listing of organizations that are currently involved. We have executive directors.
I turned down my volume.
All right, thank you. We have executive directors, chief medical officers, physicians, and other clinicians, and persons with lived experience that are on the task force. Next slide, please. So the Maternal Health Task Force has 4 different action work groups. They're working, one on care coordination and resource alignment, on maternal health data. That's the second one. The third is maternal health policy, and the fourth action work group is on education and community engagement. And throughout all these work groups, they'll be taking health equity into consideration with the strategies that are developed and the implementation plan. And we have a retreat plan next week coming up, August 10th and 11th, and we're going to be working on drafting the strategic plan for the 5-year period. Next slide, please. So I wanted to talk a little bit more about our joint path forward for Georgia, and ways that I hope that you feel that you can contribute, or there's something that we can do for you. So we are building right now a Hope for Georgia Moms website. There's going to be 3 target audiences, basically: the Maternal Health Task Force. And there, we know there's a lot of networks, persons on the task force are already involved in, and we don't want to duplicate any existing task force or coalitions, but we want them to be able to know of each other and work together. So that's sort of the purpose of that part of the website and portal. We're also targeting providers so that we have tools, for example, the maternal cardiac program that we would be developing and want to disseminate. And of course, materials that are developed, for example, the GaPQC materials, which we'll be hearing about later on in this webinar, that we could also be able to disseminate from that website, as well as the public. And that we have resources that are out there. There's some excellent data hubs that have been developed by the organizations that are also on our task force. And we also know that there's some sort of portals for services that they can access for services across Georgia. But we'd really like your input to identify other key stakeholders that you think should be involved in this discussion and real strategizing process, basically. Any trainings or resources that you think that should be disseminated widely, that others should know about in the community, and needs and gaps, so that we can see ways that we can address it. So if you look at the just this graphic on the right side of the screen, sort of this the systems view of it. So we have the state maternal and child health, the data they're collecting and analyzing, the needs that they're addressing, and the programming that is taking that into account currently, the health systems and the clinical programs that you are already implementing and are aware of, and then the community organizations that too have programming and often are very boots on the ground work going forward. So with all these systems in place, we see the place for Hope for Georgia Moms is we're working on strategic planning together on the health programming and implementation, which is important to carry out these plans. Data capacity and reporting is key for this. And also research, we very strongly support, and we really welcome ideas in that area as well so that we can support it through our grant. So this is what I wanted to present today, and now I'm going to turn it over to my colleague, Bridget Schulman. Thank you so much.
Thank you. Next slide. And next slide again. So we are all here for a reason. Most of you are probably participating in the GaPQC. So I feel like in a way I'm preaching to the choir, but I think I would be remiss without starting this conversation with, we know the reason that we are here. We know that we can do a better job. And so as part of one of the participating hospitals that is working on improving the care and structures around cardiac conditions, I know many of you, or hopefully all of us, are familiar with this slide and how much the cardiac conditions are contributing to maternal death. Next slide. So I thought I would just take a few minutes to talk about kind of how we started our journey. I love that as we move forward into this next step of this initiative together, everybody can share different things they're doing well or where they have opportunities. So I kind of just wanted to start. This list is by no means all inclusive, but when we first sat down probably over a year and a half ago and started this conversation, we made sure that we had a physician champion from OB, physician champion from cardiology, and knew that it was important to include a physician champion from the emergency room. We had nurse leadership at the table very early on as we started these conversations to make sure that was going to be supported. And then as you will hear throughout the rest of this presentation, my recommendation is to get IT or even your IT project liaison involved with this project very, very early on as well. And I'll talk about some lessons learned on that. And then if you have any project management teams at your organization, they can help sort of with the structure and as you map things out, timelines and things like that. Next slide. So, and the other thing that was really important is that on the initial meeting, to be prepared to tell the story, and we all know that it's super important to start with the why. So leveraging the data that we know and that we have available. So share the maternal mortality statistics. So nationally, this is in the headlines, and then specific to Georgia, we know that our statistics in Georgia are pretty dire as well compared to other states overall. So I think that's going to be a big piece of the conversation. Also, it was important to me to share the other indications such as preeclampsia, gestational diabetes that can contribute to cardiac conditions. So here's the state of our nation. US is not doing well. Here's the state of Georgia. Here are the things that are contributing greatest to maternal death, our cardiac conditions. And then additionally, here's some things that we also know contribute. What also might be helpful is if you have statistics from your own organization on how many patients have preeclampsia or gestational diabetes or other cardiac conditions coming to the table, if that may be helpful. And then also leverage the AIM bundles and your engagement with the Georgia Perinatal Quality Collaborative. So I know we've been engaged with the GaPQC for many years. We are implementing these AIM bundles, so give them the background on those bundles to really signify. And I know I do help with a lot of QI and reporting with things like QHIP and Blue Distinction. And a lot more, they're starting to ask, are you involved with your state perinatal quality collaborative? So that is also helpful and leverage material. So next slide. And I wanted to add this into, when we look at the reasons, so if we know that there's opportunities to do better, how is it that we are still missing the target on improving maternal care across different states and across the US? And these are not simple questions to answer, but specifically with cardiac conditions, many times what they found is there was a delay or inadequate response to clinical warning signs and clinical presentations, ineffective or inappropriate treatment, misdiagnosis, or failure to refer or send a consult or get a consult. And next slide. So I think the one thing that I've shared in meetings and that I'll share with you today, I think, that clinical pearl is, if we're going to address pregnancy-related cardiovascular disease, we have to identify those that are at risk and then get them to the right place and coordinate that care. Next slide. Which brings the focus for our team from very early on was finding a way to implement the CVD risk assessment from the CMQCC, which I'm sure many of us are aware of and probably see in your sleep, maybe not as much as I do since I've been working with it and trying to get it implemented. But, we have these overall buckets of symptoms, vital signs, and risk factors. If you have one in any of those three boxes or four in any, that is a trigger. There's a physical assessment component. And then in the next slide, there's also red flags. And so there are different ways that we can trigger this positive CVD risk assessment. So figuring out, one, how to get that built in Epic has been on our radar from the very beginning. That is why we have had IT at the table also from the very beginning. And then the other piece is, so when we do this risk assessment, what is going to be the plan, and how are we going to refer them, and what does that look like? So next slide. We took each of those sections, so the symptoms, the vital signs, and the risk factors, and they're sort of built together in Epic. It's going to be a yes/no question, and then the logic is built behind the scenes. So the nurse will complete that risk assessment. Does the patient have shortness of breath with activity? Yes, no. And then they'll hit calculate, and that logic will run behind, and the nurse will either get an at risk or not at risk message. Next slide. The other, and this just goes to the many processes that I can share at our organization. So even just to have that built, we had IT at the table from the beginning. And then I'm sure all of you are aware that there are different governing bodies. We have nurse shared governments, we have an IT council, so anything that's built in Epic. So there was a lot of steps along that way that we had to kind of jump through the hoops and the approvals to get that risk assessment approved and built. The other piece of this was our cardiology and OB team agreed that if a patient triggered to be at risk, they wanted three things to happen. They wanted a referral to our Women's Heart Center cardiology program, and they wanted a BMP and an EKG ordered. And so another thing that was very important to us in the beginning that we've kind of kept in the forefront is we thought it was very important that our cardiology colleagues came to the bedside before mom was discharged home as best to our ability. Because we think it's important that we say, we are here to talk to you because you are at increased risk because of these things, or you've triggered this, and have that conversation to make sure they understand the importance of them following up when they set up that outpatient follow-up appointment. So another piece of this was, as far as IT, was to have kind of an order panel built. So all three of these things trigger at the same time. So this is what our particular one at my organization looks like. It is an inpatient consult because we want that touch before they left home. And then that's our BMP and EKG that would be ordered. This fires automatically as a BPA or a best practice advisory. So the providers will see that when they open their order entry, and then they can go ahead and put that order in, or they can dismiss it, but it will fire again until they acknowledge it. And then the other thing that was important for our team was that they had the ability to kind of say, this isn't the clinical presentation, or that to not order it if they feel like that was the clinical presentation. So this is optional. It's not a hard stop or anything like that. But it is automatic fire when that risk assessment triggers to be at risk. Next slide. So all of that is wonderful, and we were extremely close to turning it on and starting testing, and then our organization obtained another campus. So we are happy to announce that we now have Habersham, and so that went live July 1st. But what happened is about 3 months ago, when we were super close to going live with all of the things I just described, IT had to hold all projects until they got that campus up and going, and completely integrated them into Epic, which they did not have. And so we realized we had to pivot. And so what we did is we've been working for about a month and a half to pilot a paper CVD risk assessment at one campus, our smaller campus that delivers, and use sort of this as one to see, how many people actually trigger. We can get some statistics. We can work on some of that workflow and maybe foresee some issues when we actually pull the trigger on the electronic version. We also, our intent is to use that BPA, although it won't automatically fire, it would still be available if you searched, high risk CVD. Those will still be paneled together. So that could be ease of order, even when we use the paper risk assessment. Next slide. Next slide. Hello?
Bridget, are you
Yes.
seeing?
Oh, maybe I'm frozen. I'm seeing the CVD risk assessment.
Okay, I'm having a little bit of an issue with that. Do you see the patient workflow?
Not yet.
Okay, that is up on my screen. Is anybody else seeing that? Amy, are you seeing the patient workflow?
I can see it, Lisa.
Okay.
Yes,
Okay,
patient workflow. Yes.
Okay, well, maybe it's just me then. Let me just pull it up real quick, and we can, I can kind of speak to that. Hopefully it will update. Going blind here. We'll, with a patient workflow, we start with and so this workflow is specific to the paper. So this is where we're at now, since we did have to take a pause on the IT workflow. And IT is going to pick up projects now and prioritize, but we'll start with completing the paper risk assessment on mother baby. That's where we decided to do it. And to make it easy and so that providers wouldn't be getting calls all throughout the day, we agreed that the best time to do this is at 8 a.m. When they do the morning vital signs. So they'll be screened. If they screen negative, they will just continue with normal work, normal standard of care and workflows. If they screen positive, then they will notify the provider, and they will initiate that order panel, which the providers have agreed to be a protocol. They are very supportive of this work and said if they screen positive, then we are supportive. So it would be a protocol with physician signature needed after. And then a few things will happen with that, as we talked about. We have taken, our cardiology center has hired an APP to serve sort of as the liaison between the OB and cardiology. So our APP Savannah will be notified that the patient had a positive CVD risk assessment, and as well as a BMP and EKG will be ordered off that order set panel that was created. Savannah will then, our APP will come see the patient and have that touch point prior to them going home. In most cases, if she is unable to see them prior to them going home, she will follow up with a phone call and schedule their appointment outpatient in the office. And then that's how that would go. And then I finally see it on my screen, so that's helpful. I don't think I skipped anything. And let's try the next slide. Oh, all right. So I will pause there. If time allows, I know we are going to be revealing some exciting education materials that the team has been working on, but we can pause there for questions if we have time.
Feel free to take yourself off of mute and ask any questions of Heidi or Bridget, or you're welcome to enter those into the chat and then we can relay those to Heidi or Bridget if they cannot see that.
This is Missy Kotke. Thank you so much. I just really appreciate all of this information and y'all sharing. A couple of questions come up for me for hospitals that are trying to set things up. Do you have a sense of how frequently your BPA is getting fired? Like what kind of volume you would need a cardiologist or your advanced practice clinician to be able to be, putting eyes on a person? And then I have another question about
Well,
how this communicates to your emergency department.
Yes, so the first question's easy, 0 yet, because it hasn't actually gone live in Epic due to our pause. And our paper trial goes live August 8th. So that we see as exactly kind of what you're foreshadowing there. What kind of volume are we going to see? We're going to look at our smaller campus and be able to, from this pilot paper, be able to see. And like I said, if you can just imagine IT at a big organization dropping all of their major IT projects to focus on one campus, they have to bring them all back in, and we all think we're the most important project, so they're going to have to prioritize that. So we probably have a few months to do this trial, and I will certainly bring back that information on how many actually trigger, how many we screen and how many we trigger for those original consults. And then your second question, our emergency partners are part of our maternal cardiac work team, and we meet monthly. And the long-term goal is for this risk assessment to also be done in the emergency department. So we are going to, again, take those baby steps. We're doing it inpatient was phase 1. Phase 2, we have the supportive leadership in our NGPG urgent care facilities to do a 30-day trial or sort of pilot in just their Brazelton campus as well. And then based on those results, we would take some data, how many times that triggered. And then there's 9 urgent care campuses in our healthcare that it would eventually go out to with the right messaging and when we were prepared for that. And then our third phase was the emergency department. And we actually talked about doing a paper trial there as well. So again, this trial that we're doing in Brazelton at a smaller level may help steer that as well, because as you probably know, emergency rooms are very busy. So that one more thing, having it on paper, they thought might be helpful to pilot as well.
Thank you. So there's a question that came in on the chat. Lisa, could you pull up the slide with the EPIC cardiac assessment? And Beverly, if you have a specific question for that, feel free to come off mute or to put that into the chat.
Amy, I think it's the next slide on EPIC. Keep going, please. Yes, there we go.
Yes, it's that one. Thank you. Also, I was wondering, we have here at Midtown, we've had a population of patients with, well, I'm going to say pulmonary hypertension. And I do know that we used to in the past have a way to flag it through EPIC so that all teams would know when this patient arrives to the hospital. And so I was just thinking with some of these cardiac patients that we know are at risk, is there any way to flag in EPIC so that notification is given to the appropriate teams?
that is something that we were working on again right before we transitioned out. And that would be that there would be some maybe red flag or something that lit up on the bar, so that no matter what setting, because again, we have educated our primary care, urgent care, OB, and ED. That's the 4 areas, again, with a very phased approach, first inpatient, then our urgent cares, OB offices, and then last the ED. But how can, with that patient coming in, if she's already been flagged and is already with cardiology, where can that live? That would be in a banner or very visual. And that work is still, that's going to be one of the first things we pick up when our project is reprioritized. But that is a great question. And that was kind of the question that we were ending on, how to make it known that this patient is already been screened or already a cardiac patient.
Thank you.
Mm-hmm.
Any other questions, any comments before we move on to the next portion? So I'm going to turn it over to Dr. Teresa Bird, who is going to share some of the background and the development of the cardiac education resources. And after Dr. Bird completes her portion, then we'll turn it over to Dr. Melissa Kotke, and she'll share what she and some of her students worked on to develop the Peach Card. Thank you, Dr. Bird.
Thank you. And I'm so happy to be here today. So happy to hear about the Hope Project and everything that's been going on. And glad that Bridget just gave you guys a background on the CMQCC kind of screening tools and how they've been implemented. And so many of you have worked on the committee with us to develop some resources, both for clinicians and for patients. And I'm going to speak to the resources that we created for the clinicians. Next slide. So it disappeared.
And there's something going a little funny with the deck right now. So
okay, great. So the first product that came out of this work group was a Cardio OB quick reference guide. And basic, in a nutshell, this is a spreadsheet, but it'll be available in the form of a poster, also in the form of a pamphlet that you can carry around in your pocket, and of course the digital form that you'll be able to access online. But across the top of the worksheet is of the reference guide are all the highest mortality conditions. So cardiomyopathy, pulmonary artery hypertension, pregnancy-associated myocardial infarction, aortopathies, mitral stenosis, aortic stenosis. And what we did was we also wanted to list out some of the areas where we're not as well versed, being, OB docs or primary care or ER or midwives, with the goal of being able to acutely manage a patient and stabilize a patient and essentially not worsen their condition. So many of us know that patients will show up who may have pulmonary artery hypertension, like Ms. Green just said, and show up in the ED or show up in triage symptomatic and need to be admitted and evaluated. The whole point of this is that you don't want to worsen the patient in the process. And many of us realize that we probably were managing fluids incorrectly. We could have been giving medications that are contraindicated in certain conditions. And so what we did was use information from cardiology and some other resources that we have to compile this information and put it in a usable format that's a chart that you can easily access. And if the patient has, say, mitral stenosis and the patient presents, you can go down the list to see, okay, what medications are contraindicated, what medications are safe and should be used, the general pathophysiology of what happens to the patient so we can understand how to really stabilize that patient, how to manage their fluids, what's recommended for delivery. Should she have a C-section? Should she have a vaginal delivery? What kind of anesthesia is recommended in this condition? And so all those things are things that we addressed in this. Of course, it is not exhaustive. It is just meant to be something to really help so that you don't have to dig through so much in the short term and in the acute setting to take care of a patient safely, but also give you valuable information that you may need in order to stabilize a patient until you can get them to that tertiary center. And so this was really born out of people in the work group saying what they needed when they had these patients to present. Nobody, sometimes these patients present acutely and you don't have hours to figure out that, oh, I shouldn't give her terbutaline, or, oh, I shouldn't give her this. Many times the patient presents symptomatic, but also presents with fetal things that are going on at the same time. So you kind of have to work quickly. And this was meant to help providers in that setting so that they feel like they have something else to help them in the acute care setting. So this will be available on the site. Well, all these items will, but again, it's not meant to be exhaustive. You still should consult cardiology. You still should be consulting maternal fetal medicine. But again, this is for providers in that setting where they don't know what to do initially. And before they get those people in place and get those people to seeing the patient and at the bedside, being able to manage the patient appropriately and feel like you're doing the right thing. So this is acute care, quick reference, really meant for that type of setting. Next slide. So I wanted to reference the CMQCC screening tool again. So this algorithm was meant for patients with kind of cardiac symptoms, vital signs changes. This is meant to screen every patient that's pregnant or within a year postpartum and see if they have risk factors, which then would prompt you to then order more testing and potentially get consultation with MFM and cardiology. This is a great tool, and as they said before, if these tools have been used in the case of the maternal mortalities they had in the state, over something like 80% of them potentially could have been prevented. Those deaths potentially could have been prevented. And so all of us are looking for ways to implement this. And just as she showed, Bridget showed a little while ago, they're trying to implement this in their urgent care settings, in their acute care settings. For all of those people that are at hospitals like myself that are just starting this process and are not going to get here, one of the issues that we had was just knowing where to implement the screening. And so this screening tool is really for patients who don't have the red flags, who don't have the severe symptoms, and who don't have the conditions that are those WHO class 3 and 4 diagnoses that were in the previous acute care guide. So these are all the people that are kind of in the gray area that don't stand out for their symptoms. But the problem was it's not really labeled that way. It wasn't that you had to explain it to everybody to get them to know that. And then the next slide. This is also the CVD assessment that was put together by the CMQCC for those women with the acute symptoms that also have red flags, and including a personal history of those severe conditions, cardiac conditions that we spoke about. But again, a lot of people, if you're not well versed in this, having somebody use this just wasn't really working without having to have a full explanation. So what we wanted to do was really broadly create something that providers could use and know that they could use to screen patients that are either pregnant or within 1 year postpartum, and quickly know how to use the assessment. And so what we did was we labeled it. So next slide. So what we did was label these and kind of make an infographic so that it's visually more capturing maternal cardiac warning and maternal cardiac watch. And so the warning is essentially for the patients with severe symptoms, red flags, and a history of those cardiovascular diseases that are the highest severity in morbidity and mortality. So the ones we spoke about before: cardiomyopathy, pulmonary artery hypertension, PAMI, aortopathies, mitral stenosis, aortic stenosis. So all those conditions are the ones that we wanted to raise a red flag, and those are the ones with the warning, or the patient comes in with the severe symptoms. So essentially, we also labeled the other one for the milder symptoms, the maternal cardiac watch. And so these are for patients that have milder symptoms, don't have any red flags. This is essentially everybody else, but labeling it such that you know when to use the screening tool, right? And so essentially, if a patient doesn't have any of the maternal cardiac warning signs, but they're symptomatic, then you move to the maternal cardiac watch and go through the algorithm to see if it indicates that they need to be hospitalized, whether or not they needed acute evaluation and consultation with MFM, and then to get EKGs, BNPs. So what we wanted to do is put this in a usable format that people could easily understand. Okay, this is what I use here. This is what I use here. And ideally, this will be potentially in the format that you see. It could be a poster on a wall. You can print them and have them readily available to use. We also have, next slide, badge buddies. So that was the goal that we thought in mind, put them as badge buddies that you can have front and back, and you can easily reference these when you have a patient that presents. You can easily take a look at your badge buddy and know what to do and follow that algorithm. And again, this is meant to be an adjunct to something, or kind of a precursor to being able to get these algorithms worked into Epic, because many of you may never get to that point. And I know for us, it may take a really long time, and we're working on this process. But in the meantime, I don't want to miss patients. So this was a workaround. So hopefully people and providers can use this. I think it'll be of great utility to, say, ER docs and people in primary care that see patients in urgent care, because we can distribute these to the nursing staff and the providers there to really have them pay attention, so that at least if they know the patient is pregnant or postpartum, they can use these badge buddies to help see if the patient needs acute management and in the acute setting and hospitalization. Next slide. And I'll turn it over to Dr. Kotke now.
Awesome. Thank you. Lisa, did all the slides that I sent make it into the PowerPoint today?
This was from just a little while ago, so maybe not if you had added more.
No, can you just go to what the next slide is, just so I have a sense of where things are? Okay, so did you, you may not have gotten the slides that I sent, which is
Likely
possible.
did not.
Okay, so you can back up, please. There are a couple of things that my communication just wasn't effective at doing today. So apologies to the team, but I think you have the most important things in front of you. I wanted to provide a bit of an adjunct to what Dr. Burgess presented as tools for providers in clinical settings, and to give a little bit of an overview to some of the work that we've been doing to provide some education for patients and families and communities, because as we all know, certainly cardiac events are very real and really impacting maternal mortality, morbidity in the state for people while pregnant, but that goes out very far into the postpartum time period, up to a year. And one of the things that we think we need to be able to communicate to patients clearly is to remind them that out to that full year, they should be looking out for certain symptoms and calling attention to the fact that they are indeed postpartum. We know that we have big gaps of obstetrical care across the state, and that a person may have delivered in a space where people identified them as pregnant, but 6 months later, they might not be in a space where somebody is even thinking or having a recent pregnancy in their mindset. So really to use this as an opportunity to educate patients and their families that these are this concern is real, and that should raise their awareness a little bit. So I have been working with some students, Dr. because they were medical students when they started, Patience Timmy and Olivia Van Menschoten, both of whom are OB residents now, both of whom are in programs in Tennessee. And they had started this project doing a landscape analysis, seeing that there were really great resources out there. SAMQCC, we've heard about a lot today, but the American Cardiology Association, AIM, AWON, certainly, there are a lot of great resources out there. They combed through all of the ones that were available and collated them. They did reading level assessments for them. They also identified the tools that were available in languages other than English. They also wanted to really make sure that they could turn their attention towards inclusivity in what was patient facing, and importantly included both pregnant and postpartum with a focus on cardiac. So they had done an assessment of what they found readily available. They put that together in a document that hopefully will be able to be up on GaPQC's website as well. So if you want to see the resources that are out there, you can pull them from the PDF, follow the links, and leverage the tools that other people have put out there. But then working with the education committee, who y'all have been amazing, some brilliant person coined Peach as a mnemonic to help patients and families kind of have an awareness and maybe use it as a memory tool for the symptoms that they should be looking out for. So Peach is for palpitations, P is palpitations, E is edema, A is abnormal breathing, C is chest pains, and H is high blood pressure. And you can see we've mocked up a couple of different approaches for how this information could be shared. I believe the one to the left, though it is being presented as one kind of long tool, that's actually meant to be like a wallet-sized card where people have a picture on the front with the acronym, and then on the back, that Georgia cares about pregnant and postpartum people. Cardiac issues can go out to a year. And then in the orange, which you can't see because it's too small, it does say, have a little phrase that patients or their family members can say, like, hi, I was pregnant within the past year and I'm currently experiencing this. There's also a QR code that links to some of the AIM website's patient-facing information, because there are some really good resources there. So we have mock-ups here for a wallet-sized card, and then more of like a poster. That's the one that's in the center. And then the one over to the right that you're seeing, actually, the vision of it is like a refrigerator magnet. So all of those are available. There is, I believe, either already or soon to be coming an opportunity for hospital teams to order these. And you can hopefully be able to use those in kind of whatever settings you think are most reasonable for you or needed for you. I think that is it. Also, I want to just acknowledge and thank y'all, because folks may have seen them at the annual meeting too. This is always like, in the world of quality improvement, we are not done. So if you look at one of these and it's wrong, or you don't like it, or you would like something better, please let us know, and let's consider these tools as evolving educational tools. The one last thing I'm going to add, and I know that Dr. Suchi wasn't able to be on today, but she and a couple of other MFMs have here at Emory-Grady have been working with some of our residents to do some patient-facing educational videos as well. So Natalie Poliaktoff is one of our senior residents who created the first one that I think is up and available, but really utilizing approachable language and easy to understand, right, how the physiology of pregnancy can change the cardiovascular system, and hopefully making it approachable and friendly for our patients to access as well. I do believe that the second video has been filmed. I haven't seen it yet, but there's a series coming that are going to be patient-facing. That's it. Thank you.
And Dr. Kaki, I wanted to just piggyback and add one last thing. We actually have an app that will be coming for the acute care guide as well. One of my residents has created an app before for breastfeeding for MCG, and took on the project to create an app for the acute care guide that's for providers and clinicians to be able to use, so that you can just click, okay, this patient has, pulmonary arterial hypertension, click that. Okay, what medications can I not use? So that same information will be in an app format that should be rolled out at the GOGS annual meeting. We'll also make it available here once we finalized it. And just as she said, realize that the information that's in the acute care guide has been vetted, so it is correct. But some of it, again, this is our first stab at it, so we're not perfect at this. So if you see something that looks out of place or something like that, just reach out to one of us. We'll have more iterations of the same thing as we revise it and come up with newer versions of it. So we'll fine tune it with time, but we did want to get the product that we worked on out there to the public, because some of us, we've already been using the guide itself, so we wanted to get it out there. And so if you see something that you really just think needs to be corrected or changed, then definitely reach out to us, just like Dr. Kotke said.
Thank you, Dr. Bird and Dr. Cocky. I just wanted to jump in and show everybody where these are on the GaPQC website. So I have the website up here right now. What you do is you click on resources and you'll see cardiac education. You'll go there and here are GaPQC resources. And like Dr. Bird mentioned, we're just waiting on the larger size poster for the Cardio B reference guide. We want to make sure that that's visible and that everybody can see it. So we're looking at a bigger size there, and we'll add that to that once we get that. We are, just for our active cardiac facilities that are joining today, we have 12 hospitals that have joined as an active cohort, meaning they're submitting data. We've dedicated some funds to do a first wave 1 dissemination to our active facility. So you'll all be getting some materials to help get you started. But for anybody else that wants to download, put their hospital name on them, you can do that here. You can download and use your printers there. If you have a communications team that can put together the badge buddy, the templates are here. If not, we work with a company called Standard Press, and they are working with us to help you all get these materials. So if you'd like to put an order for any of these, you just go to Steve at stpress.com, and his number is there as well. And you can let them know what you're interested in ordering. Thank you. So I think that's it, and I'll pause here. We have a few more minutes left. Does anybody have any questions, comments, thoughts? All right. Amy, I'll hand it back over to you to close this out.
Perfect. So thank you, everybody. Thank you, Heidi. Thank you, Bridget, Dr. Cocky, Dr. Bird, for presenting today. Again, all of the information is there. Please go to the website, look at that information, share it with those who may benefit. Just a reminder, we will send out a reminder later or closer to the date, but our next webinar is scheduled for September the 5th. So we look forward to having you join us at that time. So thank you and have a wonderful day.